Okay, go ahead.
Yeah. Um, Good afternoon, good evening, and good day for everyone who has joined us at this event of the World Health Summit. My name is Dr. Amit Thakur, and I would like to thank the organizers on putting the stakeholder forum on promoting UHC at this World Health Summit. May I request the organizers to advise us on the time and the structure of this particular presentation so that we can get it started. Could I ask the organizers to give us a go ahead?
Okay, yeah, the session is 1 hour and 30 minutes. So we should be done by 6 p.m. East African time.
And also, please advise me as soon as you get the other speakers, and if you have the moderator in place. Otherwise, engagement and presentation, and then turn it over to you. And could I also ask the panelists to introduce themselves and the organizers who are with us in this room?
Okay, thank you. My name is Dorothy Ankunda, and I'm a representative for the World Health Summit Africa. And in case we have any speaker, I'll be able to let you know. So I think we shall proceed with your presentation.
Thank you. Uh, my presentation will be around the session objectives and the session abstract. To the attendees, I'd like to welcome you all and thank you for the time you've given us in joining us in the discussions on stakeholders' role in achievement of universal health coverage. What we will try and do within this 1 hour and a half is to appreciate the key stakeholders to achieve universal health coverage and to realize that UHC calls for interventions that prevent ill health, such as health promotion and prevention. Number three, as you can see on your screen, is to realize that technology should be cost effective, affordable, and feasible to use. And the fourth objective is to appreciate the importance of addressing both communicable and non-communicable diseases as we strive towards UHC. So the objectives are quite straightforward and simple. And in today's session, we will cover all of those that you see here. Let me begin by saying that the session at the opening ceremony was set a very good stage for our discussions at the World Health Summit Symposium. I also want to reiterate that the role Makerere University has played has been fundamental in making sure that the stakeholders uh, are all on board when it comes to providing their support and participation. So, on behalf of Africa Health Business and on behalf of Africa Healthcare Federation and the private sector, I'd like to thank the organizers for giving us a chance in speaking at this event in the four areas that I have just explained and displayed as session objectives. Let me begin by saying that I will not be doing any PowerPoint presentation, but speaking through the key session objectives that have been outlined for this particular session at the World Health Summit. Number one is the key stakeholders. The second is interventions. The third is technology. And the fourth is around NCDs and CDs, both non-communicable and communicable disease. Let me begin by saying that health is complex. And the only thing complex about health is that we have several stakeholders that need to work in partnership to produce the right quality and amount of health which is affordable. Broadly speaking, in Africa and in the rest of the world, both the public and private sector have to work in tandem. Largely, the public sector takes the stewardship role and takes control through their ministries of health, public health facilities, academic colleges, training, and including in some countries, production. The private sector, on the other hand, takes control of areas where they see gaps in the health system, such as services. It even now starts training healthcare workers and takes a huge responsibility around production, distribution, and supply chain. So, as you can see, both public and private are all aligned in improving health by doing what they are best suited to do. One function that the government takes full charge of is the area of regulation and ensuring that the right quality services are provided at the right time by the right people across the countries. And this, as you can imagine, is a daunting task for many institutions and for many governments as the private sector starts expanding. My role here today is also to define what constitutes the private sector. And in this session objective, it's been defined as the non-state actors. Non-state actors are those who are not part of the state. And quite often, people tend to confuse the word private sector, meaning it's only commercial private sector. But private sector refers to faith-based organization, civil society, non-governmental organizations, and these are all put together as non-state health actors. And today's session is what is the role and the importance of non-state health actors in achieving UHC. I feel it's fundamental, and it is so important that you cannot really win any match when half the team is not playing. And in Africa, up to half of the service provision is provided by the private sector. And in some cases, large percent, up to 80 to 90% of the production of pharmaceuticals, for example, is produced by the private sector. Quite often we've been referred to as the sector that only looks after those who can afford to pay. At a recent study done by the World Bank and IFC across many countries in Africa, private sector looks after the rich and poor alike. In many remote facilities, you only have a retired nurse who tends to provide family planning services and even primary healthcare services. So private sector actually looks after both those who can afford and those who cannot. This leads to the fundamental question of what is the role in achieving UHC when we leave no one behind. If we do not want to leave anyone behind, we have to have both public and private sector playing in tandem and in line with the national priorities in promoting health for all. So many countries have recognized this. I have personally been on the continent for over 25 years, and in the last 10 years, there has been a paradigm shift in how leadership has evolved in the ministries of health, in the global health space, and in the private sector, where we believe partnership holds the key to success on achieving universal health coverage. No one player can and is able to provide health for all. With countries having competition for resources, it is quite clear that mobilizing resources from the private sector and the public sector together will provide a wider coverage of healthcare for its citizens. The complication here is, do we need more money for health, or do we need more health for the money? And this has an interplay in the political scenario and in the economic scenario in the country. Let me repeat the words of His Excellency Uhuru Kenyatta at a debate that we had on UHC. And this is what he had to say. If it is socially necessary and economically viable, let the private sector deal with it and provide that health in that section. If it is socially necessary and economically unviable, let the government play its role. This mix is what I consider to be the first foundation in promoting UHC across Africa. Where we believe private sector can come in and play its role, they should pick up that responsibility and provide quality, safe, affordable care to those who can pay. With those who can't, the government should rally support and resources and create structures so that no one is left behind. It's a very simple equation, but it gets complicated in many, many countries and in many, many discussions. And why is it so? Let me begin by pointing out one particular area where the complication starts. As I asked earlier, do we need more money for health, or do we need more health for the money? You all know that the Abuja Declaration stated an allocation of 15% of the national economy to be allocated to healthcare and the Ministry of Health. Less than a handful of African countries are currently doing so because of competing interests. Having inadequate funding for healthcare is definitely a challenge. But at a meeting with ministers of finance, what came out clearly was, how are the ministries utilizing existing resources? And efficiency was underscored and emphasized as one key element before more allocations are made towards achieving UHC. We have seen areas where there is graft, misappropriation of funds, and corruption. Many of you have read articles and news, even during the pandemic, on how funds have been channeled in the most bizarre and inappropriate way. It has been stated that if we stamp out inefficiencies in the public health system, we would be able to produce 40% more health than we're producing. So the answer to the question is, we need both. We need more health for the money, and it's up to us as the leaders in global health and in the African healthcare space to prove this. And we also need more money for health. So this is where the challenge lies. I also believe that there isn't a single silver bullet as an answer for UHC in Africa. Many people talk about the Bismarck model, or they compare us to NHS and maybe sometimes even the Canadian system. It's evidently clear that a system may work in a country but may not work in Africa, simply because of the demographics, the resources, and the health systems. So you cannot simply take a system and place it in another country. We have to have our homegrown UHC that addresses the problems on our continent, in our countries with our citizens. This then, I believe, leads to what I think is the best methodology in progressing and accelerating UHC, and that is stakeholder engagement. Stronger partnerships with an amazing amount of non-state actors that exist in Africa, which may not exist in countries like the UK. This is the first foundation. So I believe that this session comes at a excellent moment in time when we are discussing UHC and the role of stakeholders. There are three more objectives that I'd like to speak about as we move towards UHC, and that is interventions, technologies, and focusing on communicable and non-communicable diseases. Let's talk about interventions as the first objective. What kind of interventions should we have? What kind of interventions will make a difference? And we know for a fact that we want to prevent ill health by promoting health promotion and health prevention. Everyone knows that prevention is better than cure, but we also know that prevention is cheaper than cure. With limited resources like $100 per capita on average in Africa compared to a $4,000 allocation for health per capita in Europe and up to $10,000 per capita allocation for health in US, it's pretty evident that our resources are limited and we need to prevent conditions rather than cure. We know that healthcare starts at the household doorstep and not at the hospital doorstep. Up to 70% of many conditions that we see in our primary healthcare and outpatient clinics are preventable. Upper respiratory tract infection, malaria, TB, so on and so forth, which take a huge burden of the costs that our facilities have to bear with. So much so that the outpatient and primary healthcare costs on communicable diseases take up majority of the allocations on household expenses and out-of-pocket expenses on health. Is prevention possible? Absolutely. All we need is stronger public healthcare systems, clear up stagnant waters so that we don't have lava. We need to understand how to use the bed nets, use family planning in an appropriate manner, and keep ventilation where we can, avoiding transmission through air and droplet infections that we see at URTI. You know that maybe the pandemic, one of the advantages was the whole utilization of hand sanitizers, hand washing, social distancing. Don't have statistics, but many of the discussions we've had show a huge reduction in preventable illnesses. And if we keep this up and we keep the public hygiene up and we keep the whole matter of sanitizing up, maybe we will see a less amount of URTI, GIT infections, so on and so forth. So in this particular objective of intervention, let's focus on where it's necessary. We don't really need the big shiny machines called MRIs and dialysis and have ICUs. That's not UHC for Africa. UHC for Africa is preventing simple ailments that will keep 70% out of our hospital doorstep. That will increase life expectancy dramatically. So these interventions are going to be focusing on prevention and health promotion. Can the private sector play a big role? Absolutely. Right from appropriate diagnosis to appropriate treatment and having the right doctors and nurses focusing on health prevention and promotion. How you reward doctors and how you reward health workers also matters. For a long time, we have been looking at how could we best reward doctors in giving them some kind of remuneration on services. One challenge we have is the model of remuneration is based on units of service. So the more patients you see, the more income you receive. And in private hospitals, the more patients you see, the more income you receive. And the production and supply chain is the more drugs and vaccines you sell, the more income you get. So we have a perverse incentive at the moment, which is rewarding healthcare workers on the amount of units of service that they produce. If we start changing this into a capitation model, where there is a fixed fee for a given population provided to a certain facility or a certain professional, I believe that the health prevention and promotion focus will be heightened up. The entire health workforce in Africa will be focusing on keeping patients healthy rather than treating patients when they're sick. Right now, the focus is on treatment. When you're sick, you knock on the door rather than having all stakeholders focusing on keeping people healthy. So I think we need to change the incentive system. The second part of our objective, the third objective, no, sorry, the second objective is technologies. And the final one, before I stop and hand it over to the other speakers and colleagues, will be on addressing communicable and non-communicable disease. The second one is technologies objective. Uh, I I believe that the private sector is a leader in setting up, testing, and scaling up all new technologies that will impact healthcare positively. These technologies come in various forms, could be digital apps, could be remote patient monitoring technologies, could even be equipment that enable us to have quicker diagnosis and machinery that will produce the right amount of medicines and vaccines, as we've seen. These technologies are adopted by the private sector swiftly, and we want to see newer investments in Africa. How can we do that? We urge the government to have appropriate regulations, appropriate incentives, provide special economic zones, export processing zones, and encourage foreign investors to come and set up shop here and let our local entrepreneurs also set up and expand their own industry widely. There have been several challenges, and some of the challenges include tax rebates or tax concessions, differences in taxes across our countries, where if you export some medicines from Kenya to Uganda, they will be costing you much higher because of the duties than when you're exporting some from Kenya to Rwanda. With this harmonization under AMHR, we will see intra-Africa trade increasing from the current 17% that we have to almost 50%, which is our target. The European countries have an intra-Europe trade of up to 70%. So why don't we do business with each other like they're doing in Europe? It will grow the economy, it will increase jobs, and it will boost up the entire health system. So we do need these interventions. We need the right conditions. We need the right regulations, and we need the right mindset on attracting new investments into Africa in order for us to boost up these technologies, such as vaccine manufacturing, fill and finish, so on and so forth. I think, like His Excellency Yoweri Museveni said yesterday at the opening ceremony, this is a wake-up call for Africa. For far too long, Africa has been sleeping. Maybe this will give us the jolt that we need to enable and empower our own health systems to become self-sufficient. We should make our own consumables, our own masks, our own PPEs, our own medicines, our own vaccines. And we will also start producing enough health workforce for us to utilize these products and make health and UHC a real target that we are talking about today. Let me move to the final objective, which is the fourth objective, and that is about focusing on both communicable and non-communicable diseases. And it's a pretty important one. And this is where I believe focusing on cardiac conditions, kidney ailments, cancers, diabetes, hypertension, and all those non-communicable diseases, I think the sound and the alarm is let's focus on lifestyle diseases now in Africa through public awareness, through community engagement, and through stakeholder participation. In keeping abreast of the rising NCDs, we will ensure that we don't have a huge burden in the next decade, as it has been documented. So these are the objectives. I believe that the stakeholders like the private sector are fully aligned. What we are doing is we are organizing ourselves in associations and groups, and finally at the apex body of every country as a federation. Over the last 15 years, the journey has begun. And in Kenya, we have a Kenya Healthcare Federation. We've established similar ones in Rwanda, Tanzania, Uganda, Ethiopia, South Sudan. And we are creating a regional federation, which is known as now the East Africa Healthcare Federation. West Africa did a similar process, and they now have a West Africa Private Healthcare Federation that brings together 9 countries out of the 15. So far, we have 27 countries in Africa that have a federation-like status. They bring in all the professional associations of doctors, nurses, pharmacists, and also bring in institutional associations like the medical insurers, manufacturers, healthcare distributors. And finally, we have all the institutions and corporates, NGOs and CSOs. This unified approach of non-state health actors creates the first platform on public-private dialogue. I believe that at this PPD, when we have both state and non-state discussing the challenges of the country, they will come up with a formula that will accelerate UHC that is appropriate and affordable and optimal. Thank you so much for listening to me, and I would like to turn it over back to the organizers from here. Thank you so much.
Thank you, Doctor. Do we have any questions or from the attendees or participants? If you have any question, you could raise your hand and ask.
I don't see any question or hands raised up for now from our participants or even our fellow panelists. Dorothy, I would like to ask you if there are any other clarifications from the World Health Summit team on this particular subject.
Come again?
Are there any particular clarifications or questions from the World Health Summit team on this particular subject? I'm very happy to take that question from you or from the team.
I do not have any question from my side. We have a colleague who has a question.
Yes, of course. Go ahead, please. Dorothy, is your colleague there with you?
Yes, he's just coming.
Okay, great.
Yeah.
Thank you very much for the presentation you've given, Dr. Amit. So in one of your major visions, it's indicated that you aim at improving access to quality, affordable healthcare in Africa. But according to what is going on currently, there's this unequal distribution of medical equipment, vaccines, and all those technical advancements that we see in the Western countries that are not yet here in Africa. Now, given that you have vast experience in this field, what efforts have been really put in place to make sure that we bridge up this gap between the Western cohorts and the African communities that are really lagging behind, to an extent that it's only the rich and our politicians who fly out to those countries to get medical care and leaving the poor here to suffer? Thank you.
That's a very, very important question. And I totally agree that the health sector in Africa has been lazy. And I tell you where the laziness has come, both in the public and private sector. We were quite happy living in a global community where we could import many supplies from China, maybe India, Asia, Europe, or US. We started receiving consumables like bandages, syringes, even gloves for that matter. We never thought that there will be a global disruption where supplies will be hampered and people in Africa will end up suffering simply because a cutoff that this pandemic showed us would need us to have self-reliance much more than we thought of. Would the pandemic like this happen again? Surely it will. This has taught us to become more self-reliant. About medical travel and tourism that people go, I think it's pretty clear that we need to improve services. How will Africans stay in Africa? The only way is if we have the best spinal center, or we have the best cardiac center, or we have specialists. I think the collaboration that we need with such specialists and centers of excellence, we need to have some kind of engagement. That collaboration is what's going to change the matrix. Otherwise, the rich will be able to get on a plane and travel whenever they can, and they will say, this is what I'll do, and probably get the best for myself and my family and my kids. This collaboration has been weak. I also blame the health sector players who've been resisting in collaboration. So we need to bring the specialists home. We need to bring the specialists into Africa. We need to have some kind of structure, and maybe telemedicine and telehealth will help us bridge the divide. Obviously, in the world, there are experts in different fields in different places. We could learn from those and maybe also make sure that we refine our skills in Africa, and then we can teach maybe other countries like Latin America and so on and so forth. So I believe the function of collaboration is going to reduce medical travel. And I also believe the inequity is going to be dealt with through improved investments and local manufacturing on the journey and the road to self-sufficiency in Africa. Thank you.
Thank you very much, Doctor, for that. Are there any other questions? Okay, looks like, oh, there is a question.
Yeah, go ahead, Dorothy. You can ask me that question if you received one.
There's a question from Dr. Rachel. She
Go
said,
ahead.
for the presentation, how do we ensure to hold policymakers accountable to the health structures that they put in place and not use?
Yeah, yeah. Dr. Rachel Ayanga, that's a very important question on leadership and governance. I believe that we should hold each other accountable, and every citizen and every health sector stakeholder should hold the Minister of Health accountable on whether it is just talk or action. And through structures like engagement models that we have done, for example, in Kenya, Ministerial Stakeholder Forum, we engage every 3 months. And if we believe that the minister or the ministry are moving in a direction that is not appropriate, we have an escalation forum known as the Presidential Roundtable. And we are happy to talk about the ministry at the Presidential Roundtable. So I think having midterm framework, having media reviews, and assessing whether the policy implementation is going on is a very tedious task. But through an organized system, I think the non-state actors should be able to give a scorecard on how policies are being implemented and just not left as talk. Of course, the civil society has a very important role to play here. And I would really call upon the civil society to join hands with the non-state actors, holding public sector and private sector accountable. We also know that there are counterfeit supplies, but there are also counterfeit professionals out there who make or take advantage of poor regulatory mechanisms for their own gain. We have seen people engaging in unscrupulous business, and this again should not be allowed when it comes to enhancing policy across countries. So I think accountability requires two parties to be assessing, and there's a space for escalating non-performance of policies that just remain on paper. Thank you.
Thank you very much. We have another comment. Thank you, Dr. Rachel, for your question. We have another comment from Anne Nisima. She says, I like your presentation, particularly focusing in strengthening health systems. What I seem to be uncomfortable with is placing the private sector at the forefront of providing health services to the people. I really believe that the government must take a leading role, maybe putting regulations and all that.
Yeah.
Do you have any?
Yeah, thank you. Thank you for that question, Anna. Um, I wish that was the case, but for the next 50 to 80 years, I don't see that as a case in Africa. And the reason is simple. With limited resources, if government took the forefront and took full responsibility, we will not be able to provide quality health services for 1.3 billion. And that I can guarantee you. And that's why we cannot compare it to the UK and other countries. So the private sector does have a role. In fact, so much a role that if you ask anyone in Africa, if you had money, where would you go for your treatment? Ask and do a poll. You will see that close to 90% will tell you private sector, because the private sector receives the fund and focuses totally on quality because they want the client satisfaction, and they would have the nurses with higher morals and doctors focusing on that. If you go to a public facility, they probably have no particular idea and have no care about the queues and the systems. I'm a doctor who I trained here at the University of Nairobi, and I worked at the public sector. The conditions are appalling. Maybe even the motivation is very low. And you ask anyone, now we have a problem there. The quality of service is absolutely not liked by Africans in the public health system. So we need to fix that. Until we don't bring that up, how can we have them leading healthcare for our families in the forefront? It's impossible for anyone to even go there if they have the funding. How do we change it? By strengthening them, by providing the right conditions of work. We also need to provide remuneration and appreciate the health workers who work in the public health system. Until that doesn't rise up, it has no chance of being a leader in providing health services for yourself or your families or for the community. We will always have a mix. What can private sector do? I think the private sector can continue providing services, but it needs to focus on costs, keeping it affordable, so that more people and more community members can access this care. We have relied on global imports for so many years. Every time there's a dollar fluctuation, the private sector changes its price. So if we were to produce all the goods and consumables and medicines locally, I believe that the private sector costs can come down dramatically. And this will have a multiplier effect on the healthcare systems. Thank you.
Thank you very much, Doctor. We still have more comments and questions. We have one from Charles. He says, don't you think that many state officials own and have private health facilities and so think only about their gains than implementation of free equity healthcare strategies in Africa, especially in Uganda?
If any health official in the ministry has their own facility, I would state it as a conflict of interest. They need to declare it and possibly walk out of that because there is a total conflict of interest. However, I think everyone has a freedom of investing in anything that they believe will add into the economy. You can have a hotel, you can have a hospital, you can own a factory, you can sell shoes, you can sell digital. So I don't think we should limit anyone on any trade. However, there should be clarity of conflict of interest. And if in Uganda, you are literally seeing this conflict of interest having an interplay, then we seriously would need to table it at the presidential level, at the Minister of Health level, and clarify it. You can own shares, but if the conflict is to strain the public system and make it absolutely weak so that your private facilities stand to gain, that I believe is a case that should be tried in court. You take an oath of public office to start supporting and increasing public health services. And if you do the contrary, I think you should step down or resign from that position. Thank you.
Thank you, Doctor. Thank you, Charles, for your question. We have another comment from Geoffrey. He says, thanks for the presentation. My challenge, however, is the public-private partnership. Let me read that again. My challenge, however, is the public-private partnership that needs to be strengthened if we have to realize a better health system.
I fully agree with that statement, and I think that's what I intended to do in this 1 hour. And if I'm getting a comment like that, I feel relieved and I feel pleased because I fully agree with that comment that we need to strengthen it. And I believe it's the only formula for Africa to have life expectancy increase. It's through an effective PPP model in healthcare. Thank you. Dorothy, is there any more?
Then submit them now, and if not, then you end it.
Okay, if there are any more questions, you could submit them now. And if there are no other questions, yeah, we have one from Charles again.
Okay.
can universal health insurance be implemented in low-income countries?
Charles, it's a very good question. Let me begin by saying I would like us at another forum talk about the word insurance and universal health coverage. They mean two different things. So I hope when you wrote you meant universal health coverage. Insurance is a word that will best make sure that we don't produce healthcare. I feel that we should ban the word insurance from universal health services or coverage. Insurance is meant for an industry that collects premium, and that premium is collected and the claims are lower than the premium and there is a profit motive. Universal health coverage does not need you to belong to a membership plan. And if anyone says that 1.3 billion people should be members to produce health, in my opinion, it's the best way to reduce healthcare on Africa. I believe coverage comes from many ways. I think plans are better than insurance premiums, and the plans will allow communities to become a planned model for receiving care at a health facility, not necessarily having membership. You also need to have medical plans around companies where they cater for their staff and their families so that they can receive care. Some companies have a hospital and they have clinics that provide services. That's also part of universal health coverage. But if there is a thinking that you must belong to one insurance plan, which is the National Health Insurance Plan, I think it is the beginning of failure. And I have seen this happen politically in many places in Africa. And I think it is being the highest level of confusion when people are saying you need to belong to a state insurance in order to look after yourself, your families, and the communities. I think the best way in Africa is the African fabric system of UHC. Different fabrics in West Africa to East Africa to South Africa, and different fabrics of coverage in communities. So smaller pockets of medical plans is the best way for UHC. Thank you.
Okay, thank you very much, Doctor. And thanks to the participants. Looks like we do not have any other questions.
Okay. So I want to thank all the participants, Dorothy here. I want to thank the organizers, and I do want to thank Charles Ibingira, specifically from Makerere University, and all his colleagues who've put this entire amazing World Health Summit in Kampala. Many of us would have liked to travel. Unfortunately, we cannot travel. We wish you, all of you who are in Kampala, all the best. We know we have a session tomorrow, which is the final day of the summit. And from Nairobi, Kenya, greetings to everyone. Have a pleasant day. Bye for now.